Yeah, I had this night was not so good. I had some problem here of sinusitis.
Oh, do you? No COVID.
Yeah,
No COVID.
yeah, no. I
Good.
hope not. I hope not.
Yeah. I hear you. You are sneezing.
Yeah, the weekend here is changing. The weather, is cold.
Well, you have winter.
Yeah.
We are in 30s. It's hot.
Yeah, here it's cold. Here it's cold. It's cold.
Yeah.
How is it going? You okay?
Fine. I just had COVID 3 weeks ago. I got it in Mexico. I don't know how I could have, but I still got it. And it's not a pleasant disease, I can tell you. Despite 3 shots and despite everything, I had it, and my wife got it too. So we were rather suffering for a while.
Yeah, me too. Had 3 shots. My wife also had 3 shots and had COVID.
And then the same.
Yeah, the same. I didn't get, but maybe this time. Tomorrow I'll do the test.
I thought I had it. You know, I never got it.
Yeah. Okay.
Hello, Maria.
Good. She's okay.
Very good.
Okay. Yeah. We just went 3 weeks ago to Sarajevo with Karen Arnautovic. It was very nice there.
Sarajevo is nice. It's a nice place.
Yeah.
Nice
was there.
He told me he was traveling. Yeah. Are you going to Jerusalem for double?
No.
Oh.
No. Are you going there?
I am.
Yeah.
Well, that's a good trip anyway, you know, a good congress, and Jerusalem is a place to see. I've been there several times and I'm eager to go again.
Yeah.
And do you go to Nairobi in November?
No. I'm in travel. Jalal, how are you?
How do you do, Professor? How do you do, Professor Papa? Professor Vladimir, good to see you.
Good to see you too.
I missed your meeting because I did not get the visa to Brazil. Maybe next time.
Yeah. Was difficult to get or too late?
No, difficult to get. I get it before 10 years because it was easy for the Syrian people. But now you are a refugee. You cannot have the visa. So I did not have it.
Yeah. Always problems.
Crazy.
Yeah.
Crazy world. Yeah.
You got
Hello,
COVID,
Maria.
you got war.
Yeah. Terrible times.
It is.
And I don't know what's happened. See,
you know, the war is dangerous now. It's not a good thing. It's too close and too many refugees and too aggressive.
But soon will stop or not?
No, they won't. The Ukrainians will never give up, and he cannot win. So it will last long. Yeah. We all will get poorer.
Yeah.
It's really expensive entertainment.
Yeah, let's see. Hello, Maria. How are you? She's here.
Maria is reading something.
Yeah. She's preparing. She organized everything. Every day. She's very busy. Yeah. No. This program we used to have every 1 or 2 months. It's a lecture for medical students. You see, for medical students and residents.
Right.
And it stay record, and the people watch from around the world.
Yeah, this is easy. This is what COVID did to us, and it's the only positive thing, these webinars. You reach far many more people.
Many more.
Yeah. No fee, no hotel, no flight, you know, it's for free.
Yeah.
The trouble is that we are not seeing each other frequently enough.
Yeah. There are no more social meetings.
No, very few.
Just same thing, yeah.
No.
Yeah.
But the event in Rio was excellent. The skull base in March. It was perfect. You did a superb job.
The hotel was nice. The weather was nice.
Everything was perfect.
Hello, can you hear me? I think my mic was turned off. I'm sorry.
Yeah, you can hear you now.
Yeah, I'm really sorry because I think my mic was turned off. I'm really sorry. So thank you so much for coming, sir. I really wish you a brisk recovery from this sinusitis thing, sir. I've just came to know, and unfortunately, we cannot have your lecture today on infratentorial meningiomas. So I hope we can arrange a part 2 of our meningioma module, sir, if you like, when you are feeling.
Let's go, Tim. Let's watch. Let's see what Professor Vladimir said to us today.
Okay.
Exactly.
You both. Let me share the screen.
Okay, Maria, you can give a small introduction, Professor Vladimir. I can talk of something about him. Can you start to record?
Exactly, sir. I'm just recording it, sir. It's also right now on YouTube, so we will have the recording on YouTube as well after the show. But I'm also recording it myself on my computer as well. Yes. It has just started, sir. Sir, I think that it's we've got time, so it's time to start now, sir. I will be really pleased to hand over the floor to you to Professor Luis Borba to kindly introduce Professor Vladimir Benz for our today's module number 4 on meningiomas. Sir, Professor Luis Borba, it will be a matter of huge pleasure for me if you proceed and kindly introduce Professor Vladimir Benz for the module 4 and for his amazing lecture, like always, on supratentorial meningiomas.
Good morning, good evening. Professor Vladimir, thank you very much to be with us. Professor Vladimir is very well known neurosurgeon, professor from Prague, from Czech Republic. He talked to us about meningioma, the supratentorial meningioma, and give an overview of this area, some hot topics, and can understand this area. Professor, you have all the time. Don't worry with time. You need time to show your head to you. Thank you, Professor. Thank you.
Thank you. Thank you, Luis, for introducing me, and thank you for inviting me to this event, because I believe that any teaching and any let's say work for WFNS is valuable, and it has usually a great impact. My topic today is supratentorial meningiomas, and I of course will restrict or not restrict, but I will talk more about the skull-based meningiomas, because those are the difficult ones and the important ones. I do not have anything to disclose. I never ever had. And the lecture outline will be first, I shall talk a little about the difference between the skull-based surgery and cerebrovascular, because there is a major difference. Then about the arachnoid and at the base of it and systems. I shall show you the olfactory groove meningioma as an example of value of arachnoid membrane. Taxonomy, mostly skull-based, of course. Tuberculum, clanoid, middle fossa, planial rectus, and convexit, a little overlap with Luis Borba, I suppose, and then some general remarks and conclusions at the end of the lecture. It's all based on some nearly 2,000 meningiomas, which we have had in my department over the past 20 years. nearly half of them were skull base, and you see the wing, clinoid, and olfactory were the most frequent ones.
Vladimir,
What is the...
Vladimir,
Yes, please.
can you put in presentation screen? Yes.
Slide share, sir.
I do.
Slideshow.
It's not on presentation mode.
No, no.
On my screen I have a presentation mode, so something's wrong. So I will stop share. And let's share again.
Sir, I think you use the Mac system. I think you have got the, yeah, exactly, sir. Perfect.
Is it all right now?
Okay.
Okay, very good.
Yes,
Sorry for that. On my screen it was in presentation mode, but now you have it as a presentation mode, don't you? So we are talking vascular, which module disease aneurysms, and this is subarachnoid surgery. You cut the arachnoid, you open the cisterns. Unlike in meningiomas, which should be extra-arachnoid surgery, you lift the arachnoid, the outer membrane, and you preserve all the other membranes. So this is the border between the skull base and between the vascular neurosurgery. Let's see the aneurysm surgery. Dissect all the cistern in the skull base, and you see basilar artery, opposite side from middle cerebral, whatever you want to see and whatever you want to do. You are in a space which is between the ependymal surface of the brain and the outer layer of arachnoid. One approach, then you can as many aneurysms as you want, and it should be just in this space, not going outside or inside anywhere else. Looks like that. This is the ophthalmic aneurysm. Here you see the stretched optic nerve. The canal is unroofed, and we are at the border of chiasmatic cistern and carotid cistern. The aneurysm is within the carotid cistern, and by dissecting the arachnoid from the aneurysm, you preserve the arachnoid on the optic nerve. You preserve the vasculature of the optic nerve, and you just are able to preserve the vision. You see the end plate, the shiny structure is the arachnoid covering the optic nerve and the vasculature, and definitely the patient improved his vision after the surgery. So now we are in the subarachnoid space. With tuberculum cell meningioma is just the opposite. You lift the membrane. This is the tumor, the optic nerve, and here is the arachnoid layer of the chiasmatic cistern, which is not cut but lifted from the tumor. This is at the end of surgery, and you see that the arachnoid is still preserved, covering all the structures which are hidden underneath. This is clinoid meningioma. You see the arachnoid here. This is the arachnoid of the carotid cistern. If you do not penetrate it, you cannot harm anything. And the surface of the tumor is not shiny and light, then it's wrong, then it's arachnoid there. The surface of meningioma is always rough and pinkish. So this is the proper plane of dissection. Let's now go for olfactory nerve. What this is all about. See the two identical olfactory group meningiomas. The difference between the two is fold. First, edema in this case is unilateral. In this case, the edema is bilateral. The anterior cerebral artery in the left-hand case are shifted, not in this case where they are in the midline. What does it mean? The left side will be covered in some by 3 layers of arachnoid, difficult to penetrate and difficult to harm the frontal lobe. And the same will be for olfactory system, which will be pushed to the side. And in this case, you should easily be able to preserve the olfactory nerve, and that's the function. Unlike in this case, where it's in the middle and everything is covered by one single layer of arachnoid only, and the danger to the olfactory nerves is much, much greater. These are more difficult tumors. It looks like that at the end of surgery, and you see the remnant of the tumor in the olfactory. The olfactory nerve is over here, and you see that it's nicely preserved along with its cistern, and this means that we are able to preserve the smell of the patient, which is rather important. And sphenoidal tumor, and you see that the olfactory nerve, even ipsilateral, can be dissect-free, thus preserving. We've published that, and in cases where in olfactory groove the smell was preserved prior to surgery, we were able to save the function in 70% of patients. So this is all about the cisterns, and I'm going to talk about the cisterns mostly throughout the lecture. There is not much about the anatomy. This is, of course, from Al Rotten's book, and those are the drawings. Those are not photographs. And the impression that the cisterns are well-defined and well-defined spaces which are divided by the arachnoid membrane, which is not really that much true. This is by Kuruc et al. Those are two excellent articles on the cistern anatomy with the use of endoscope and fresh cadavers. And you already see here that only the Lillienquist membrane is the firm structure. All the other inner layers of the arachnoid are very penetrable because the CSF must flow. So it's not; those are not really the walls. This is what we did. I will show you soon. We were meeting in teams where they have excellent anatomy lab, and we were just dissecting there. Then I sent one of my residents there, and she developed the technique how to remove the skull base and then going for the cisternal anatomy. And these are the specimens she did. You see here the carotid cistern is open. It's a well-defined space, both third nerves, stalk. And here is the arachnoid membrane of the Lillienquist, and you see that that's a real true wall dividing the supratemporal and infratemporal compartment. But in this space, we should have spinal cistern, prepontine cistern, interpeduncular cistern, and you see that there are only trabecules or only pieces of arachnoid. So this is not really well-defined spaces. They are more or less arbitrage. See how difficult, let's say, in the entrance of the third nerve underneath the tentorium into the cavernous sinus, you got carotid cistern, you got ambient cistern, here you got the cistern of the third nerve, and you see that those walls are not really walls, those are only parts and sustentacles and trabecules of arachnoid. They help throughout the surgery. But the only layer which is really firm and which is the most useful is the outer layer of the arachnoid, because you are working in the dura and the arachnoid, if possible. Not always it's possible. So arachnoid and cisterns in meningioma surgery, skull base, and as I will show at the end, also with convexity, is planning the advanced approach with advanced knowledge of cisterns and expetic layers. Exact tumor origin must be defined. For this, you have tools that you can define the origin of the tumor quite easily. Define in which cistern we are doing a drop. This means what structures are in which cistern and which structures we are to expect in our path. If possible, stay within one cistern. There are single versus multiple cisterns concept in meningioma, and a lot of meningiomas are single cistern tumors. So this is cistern-oriented meningioma surgery or arachnoid-oriented meningioma surgery. If this table with respect to cisterns, which arteries are there, which veins are there, and which nerves are there, and it's not a shame to refer to this table before surgery just to make sure which structures you are going to deal with. This is an example. Edge meningioma, a small one. There are two cisterns which are going to be affected, crural one and ambient one. This is the anatomy of the same region. You see the crural cistern with of Rosenthal and choroid artery, and the ambient cistern with the fourth nerve. And this is after the resection of the tumor. This is the space we were using between the crural and ambient. This is the mesencephalon. Here we see the Rosenthal vein, which is still covered by the outer arachnoid of the crural cistern, and we see the fourth nerve still covered by the outer arachnoid of the ambient cistern. So perfectly safe surgery, perfectly cistern-oriented surgery, and in a way, easy surgery despite the fact that the tumor was rather deep. All this knowledge, in a way, is reflected in any classification system of the meningiomas. The most important one, Yashargil and Almefti, and you see that Yashargil has a midline tumors, which is olfactory groove, planum, and tuberculum. The rest is posterior fossa. Then paramedial one, which is crinoid, one of the most frequent ones, sinus and petrous apex, the upper part of the petrous apex, and then lateral tumors, which is mostly sphenoid wing, roof of the orbit and middle fossa. The same is with MFT, who divide them into the central and peripheral ones, but actually the classification is virtually the same, and any other classification system which you may find in the literature will give you the same information. So let's go from tuberculum to the others. This is a typical tuberculum meningioma, and this is anatomy. The resection, you see that the outer layer of the asthmatic system, which is affected by meningioma, is preserved. Thus the optic nerves are covered by the arachnoid, and you will not harm the patient. This is the region we are moving, and you see that the outer layer of the arachnoid in this region is pretty firm. This is the opening we did during the dissection, and you see the chiasm within the chiasmatic system. This is the meningioma of the tuberculum again, being approached from the same side. They are not really symmetrical, they have some side preponderance. And this is, let's say, my impression that they are better to be approached from the opposite side, because working underneath the ipsilateral optic nerve is not really easy. And if the tumor origin is located below the optic nerve, that's hidden, you hardly reach it. You see where is the tumor origin, just below, and this necessitates some movement of the optic nerve. This is carotid artery, so you work underneath the optic nerve, you work between the carotid artery and the optic nerve, necessitating rather lots of manipulation. And this is coming to the tuberculum cellular meningioma from the opposite side, and you see that there is a lot of space. You can drill the optic canal directly. Direction the tumor penetrates into the optic canal, thus the drilling may be restricted. This is the ipsilateral optic nerve, the contralateral optic nerve, contralateral carotid artery, and you see how nicely the tumor remnant can be dissected free from the optic canal. So this is still under debate whether you should approach these tumors from ipsilateral side or from contralateral side. You see the last tumor remnant being removed from optic canal. So some tips and tricks for these tumors. I like this contralateral frontolateral approach for tuberculum cellular meningioma. I love lumbar drain. I always use, I think that this is the best invention in neurosurgery. So in tuberculum, there's some cc's, and then the next CSF drain is by opening the carotid system laterally to the tumor. Then you go for the tumor, lift the system outer layer, coagulate the tumor origin, the tumor from the skull base. Before you remove it, decompress the tumor. Then you remove the supracellular part and try to preserve all the arachnoid. Open the optic canal if necessary on the side of the tumor, even bilaterally. It's good in younger patients where you expect the long survival, and at the end the tuberculum, which gives you the symptom one resection. Let's go to the clinoid, which are the frequent tumors. They usually are really restricted to the system like this. You see the black line over here. This is the arachnoid membrane of the carotid system, which is covering the carotid. So carotid artery is not really encased despite the look of it. This is the anterior lobule of the tumor, posterior lobule of the tumor, and the carotid artery will be easily released. You see after surgery, this is the chiasmatic system which is preserved along with the arachnoid of the optic nerve. And this is, of course, carotid artery, posterior clinoid process. And here there are 2 layers of arachnoid, Lillienquist membrane, and more outer the membrane of the carotid artery, carotid system. So you just are working in one system only, exposing only the carotid artery, nothing else. This is the multisystemic tumor, again clinoid, again encased but the distal arteries, they usually have very good plane of dissection, unlike the carotid. I will show you soon. And you see that part of the tumor is in the lamina terminalis system, which is dissected free over here. And you will see that again, even the lamina terminalis is still covered by its own arachnoid, and you do not harm the chiasm, you do not harm any other structures which may be there, like Heubner's artery and A1s. This is after the surgery. What about the clinoid tumors? They were very nicely classified by Samal Meft in 3 types. The type 1 being the most dangerous one because it's growing within the carotid cave, and in the carotid cave, the carotid is not covered by the arachnoid. I will show you very shortly. Then type is on the top of the clinoid. These tumors are large because they do not have any important structures in its vicinity. Then we have those medial ones, which are rather small again because they affect the optic nerve very soon. And then I would add the 4th one, which is the temporal one, growing on the lateral side of the clinoid, and thus being able to affect the cell nerve, which is underneath the dura of the cavernous sinus there. This is our anatomical study, and you see that Mefti was right in saying the first 2 or 3 millimeters of the is not covered extradurally by the all right.
Jambo.
Yeah. Someone's playing. Should be some
Please,
kids.
Dominic, turn off your microphone. Turn off your microphone.
Do you hear me well?
Yes, I've muted him finally. Yes, I've been trying to mute him. Yes.
Good. All right, so I shall continue. And you see that here's the optic nerve in its canal. Here is the arachnoid starting some 3 millimeters distal to the ophthalmic artery origin. This is the distal ring. So this is the dangerous place for clinoid meningiomas, because as soon as the meningioma is directly in touch with the structures, it becomes very, very aggressive. On MRs, you would expect that the carotid will be narrowed here, and it's exactly the spot where it may be injured during surgery. Let's see 3 cases. This is a female of 63 with visual deficit, 5 months, no remarkable history, tumor, and this is the surgery. You start with clinoidectomy. This is the orbitomeningeal band, which is to be cut. Then the outer layer of dura of the cavernous sinus is exposed, and drilling continues along the clinoid. It's all extradural, and in some cases I removed the clinoid extradural. In some cases I just free, like in this one, because I do not know in advance its relation to the carotid artery. So I leave the tip of the optic canal. I leave the tip of the clinoid inside for intradural resection. I only remove it when I see the carotid artery and when I know the relation between the carotid tumor and the clinoid and dura. So this is the case. We are now already intradurally. You see the broken off tip of the clinoid, which is now being detected, and all the time we are just removing the tumor. All this is already the tumor. Then exposing the optic nerve, which is here, and which is somewhat more horizontally running, being put by the tumor. This is the distal ring of dura, which is being cut. and just underneath is the carotid artery. And by now, I already know the relation between the carotid, between the and here's the exposed carotid, and you see that there was the arachnoid of the layer. This is the ophthalmic artery. This is the optic nerve, which is nicely covered by and protected by the carotid. And only then I remove the tumor, and this is the final view of the situation with the optic nerve A1, M1, Heubner's artery, A1 again, optic nerve. This is after surgery, the vision improved. She has a partial third nerve palsy, which cleared very soon because it was just warmed up by coagulation, most likely. Another 31 years old, visual deficit during pregnancy, which is rather typical. Then delivered a healthy baby. We were able to wait. She was otherwise normal. This is the tumor, and this is what it looks like. Again, extradural craniolectomy or breaking off, and now we are working between the optic nerve and carotid artery. This is the distal ring, and you will see the reason why I do not resect the crinoid in the first place. Here is the carotid artery. The tumor is directly attached to that and very invasive against the wall of the carotid. You see the carotid in front of the tumor and posterior to the tumor. And here I was really unable to free the carotid artery entirely. It was very, very invasive. So piece of the tumor was left behind, being coagulated. And you see that in tumor origin, there is still blood running out of this tumor origin. Then the tumor is removed. We shall see the final image as the tumor is resected. Carotid is still hidden underneath the tumor. Some small remnants may be resected, but not entirely, because there's really a big danger to injure the artery. You see the carotid, you see the tumor and carotid in front of the tumor. So a very tiny piece left behind, but the resection was sufficient. And this is the later the vision returned to normal. And the last one is 52 years old. Again, on the left eye, other deficit. You see the tumor, it's really within the carotid cave. No other extension of the tumor, but as it pushes the optic nerve immediately, you see it. And here the tumor is surrounding completely the optic nerve. The optic nerve is underneath the tumor, medial to the tumor, lateral to the tumor. So again, quite a lot of drilling. The whole carotid optic crest is resected, and then the tumor is removed from the medial part of the optic, which is here, squeezed to the and flattened. Somehow I injured here something when I was removing the tumor. I thought it was ophthalmic artery, which I thought you will soon you see the tumor, you see the optic nerve, you see the sudden brisk bleeding. I just tamponated it, tried to put a clip on. I thought it was ophthalmic artery. The source of bleeding ultimately was seen that not. Now we are medial to the optic nerve. See the optic nerve here, and the tumor, the lateral portion of the optic nerve, all the time being removed. Now we are again lateral to the optic nerve, here the carotid artery, which is undamaged, and surprisingly, ophthalmic artery was undamaged. Although I do not until now know what was the source of the bleeding. And you see the optic nerve here, and now everything's cleared. And at the end, you see the arachnoid of chiasmatic system and arachnoid of carotid system, which never ever was penetrated. So we never ever were close to the important structures. You see the image, chiasmatic system and carotid system, and the optic nerve, which is being free. This is the region where we were doing our surgery, just underneath the optic and around the optic nerve. This is the tip of the crinoid, post-op CT, showing the extent of resection. and post-op MR with no tumor remnant seen. The vision further deteriorated because the manipulation of the optic nerve was really extensive, but 3 days later, the patient is already counting the fingers, and ultimately after 2 months, the vision returned to normal. So that was rather good results. It's perional rather than frontolateral, because with perional you have more angles of approach, and I would admit that I do not like this eyebrow approaches because of a very restricted space. So the small craniotomy is not always the advantage. Detach or remove the anterior clinoid extraurally, which helps, and you already deal with all the blood supply. Stay extra-arachnoid, it's again the same thing. Open dura from medial to optic nerve to the tip of the anterior clinoid, the dura link. Find the tumor origin, like in that second case where it was really carotid artery or very close. Detach the tumor, open optic canal sufficiently. You really would like to inspect the optic canal in almost all the cases. Remove the tumor and plug the cavity after the cranioidectomy by piece of fat or muscle or whatever. Go to middle fossa. Actually, majority of tumors or of supratentorial meningiomas are growing in the middle fossa or at the border of middle fossa. Is like an angle between the sphenoid wing, between the petrous bone and carotid sinus, which is logical because the meningiomas are growing from arachnoid cells, and these cells are most frequent along the sinuses. So this is the sphenoparietal sinus running with the sphenoid bone, carotid sinus in between, intercavernous sinus, which would be tuberculum cellae, and superior petrosal sinus running on the top of the petrous bone. So this is the frequent and the most frequent site of origin of the tumors. And middle fossa actually and its borders is the most difficult anatomy in the human body, with all the content of cavernous sinus, optic nerve, and all the other structures. Also difficult to access, and there are many approaches to the middle fossa. The working horse being the perional or anterior, the lateral, subtemporal, which is a good one. Then these transpetrosal approaches, which I do not like much because the approach shouldn't be more difficult than the tumor removal. And then in selected cases, supracerebral infratemporal approach through the tentorium. So what's there in the middle fossa? Tuberculum and cella, sphenoid wing, anterior clinoid, sphenoorbital, and you all know that the sphenoid wing meningiomas tend to be located more in the middle fossa than in the anterior fossa. Those are more middle fossa tumors. Cavernous sinus and McCabe, anterior edge, proper middle fossa, and superior petrosal sinus, its upper pyramid surface. Majority of these tumors grow infratentorially, and I'm sure Professor Borba will talk about them quite a lot. And then there are also petroclival tumors. See these complex tumors which are going from the orbit to petroclival area. So it's orbitosphenopetroclival tumor. Those are the difficult multicisternal events within the cavernous sinus. With the cavernous sinus, I do not like to enter the cavernous sinus for meningioma because it's a difficult undertaking. You call the double vision, which is nothing you would like to have. You endanger the carotid artery with all the possible consequences. As long as we have radiosurgery available, it's better to leave it for either observation or radiosurgical. So what we do is we restrict our resections to outside the cavernous sinus, like in this case. You see that the tumor is remaining within the cavernous sinus, and we either will radiate the tumor or we shall observe the tumor, depends. Maker's cave, again, you may enter the Maker's cave, but it's better to leave the piece behind for radiosurgical treatment. Tentorial edge meningiomas, those are very specific tumors growing posterior to the main arteries, and all the tiny perforators from A1s and M1s especially are stretched over the tumor. So those are the tumors where extreme care should be taken to arteries and perforators you see after surgery. Again, the pterional approach. The posterior glenoid tumor, and I believe that the posterior glenoid tumors are the most difficult ones, but as long as they are posterior to the Lillienquist membrane, posterior to the arteries, I somehow believe that they belong to the posterior fossa, but still the approach is from above. Again, the pterional approach or subtemporal, you see the regular pterional approach with glenoidectomy again, and see that the tumor is really growing posterior to the vessels. Here is the carotid artery, here is the tumor. Of course, the first structure to be endangered will be the third nerve and fourth nerve going along the edge. You make the posterior to the fourth nerve. In this case, it was not necessary because the tumor was surprisingly easily delivered out, and at the end of surgery, now you see the tumor still holds for something. But anyway, the posterior glenoid tumors, I consider them to be the most difficult ones in meningioma surgery. Of course, very helpful, even, and at the end, the tumor is attached only to some tiny vein going to the hippocampus, which it was not really a big deal to cut. It was preserved. This is after surgery. Sorry for that. So, anterior and posterior glenoid tumors are somehow difficult to distinguish on coronal section. They are easily distinguishable on axial. You see that glenoid tumors are anterior to the vessels, posterior glenoid tumors are posterior to the vessel, thus making them really difficult undertaking. Middle fossa are not difficult tumors. They are easily accessible by any approach you may choose and you feel comfortable with. This is a upper mid-surface tumor subtemporal approach. You do not need to retract any brain should the approach be sufficiently basal, and don't take your time with drilling the bone, which may hinder your approach. This is a young lady who's having communicative disorder already. You see the edema around the tumor, so we didn't want to retract any brain. That the approach was from infratentorial through the tentorium. This is cerebellum here. Here I'm cutting the tentorium down to the superior petrosal sinus. This is the posterior cerebral artery over here. And you are just removing the tumor the same way as from any other. This is on the posterior edge of the tumor, cutting the tentorium. You see that there's lots of space without any retraction, without any passing the neural structures. And at the end, the resection is exactly the same as anywhere else. Bulking the tumor with CUSA and then removing the tumor by the ordinary way with preservation of all the structures. This is after the surgery, and you see that the temporal lobe is completely unmoved and undamaged, the cavity being quite clear, and the symptomatology, of course, cleared very fast. So in middle fossa, there are variable tumors in many locations. You need some individual approach. Of course, the pterional with temporal deviation is working. Subtemporal is not a bad approach. Rosectomies, as I said, I do not like them much. And supra-infra resections are probably the best. Again, the lumbar drain, but a little bit more of drainage because you will need some more resection in this case. Certain fourths are the nerves which are endangered during the resections. Partial resections in middle fossa is seldom. You, with the exception of cavernous sinus, you are frequently able to do section 1 resection. And of course, the approach to the lesion, not vice versa. This is the general rule which should be applied to all tumors. And of course, choose the approach with which you are the most familiar. It's very important that you feel familiar and you do not need to concentrate yourself on the approach, but on the tumor. Let's go to the trochlear. Those are more or less posterior foci tumors. I believe that Luis will talk about them sufficiently. Most frequently, I approach them from supra-infratentorial, not the midline, the unilateral supra-infra. And they are of two kinds. They are pure near tumors, and they are tumors of the sinus rectus and the region. Care about the deep drainage. The vein of Galen and rectus sinus may be occluded, and the inferior sagittal sinus may be the only drainage of the deep venous system. In one case, a few years ago, I cut it, and it really was the only drainage, and the patient ended up for 3 months in the ICU. He finally recovered, but that was really one of the most difficult post-op courses I've ever seen. Check the sinuses, check the drainage. If the sinus is occluded, you can go for the radical resection, but you must check where the drainage is going, where the deep venous drain is located. See after the surgery. In some cases, you intentionally would leave behind a piece of the tumor which serves as a plug in the rectus sinus, because you wouldn't be able to hit or to occlude the rectus sinus close to the trochlear, like in this case. So a little piece was left behind for observation. Then there is this cistern, which is quite frequently forgotten. I suppose you know that. It's velum interpositum, and this is the pioneer tumor which is extending into the velum interpositum. This was the last bilateral supra-infra I did. And you see again, we are in the pioneer cistern, opening the arachnoid of pioneer cistern, slowly exposing the tumor. Then there is rather a large extension of the tumor underneath the left temporal lobe, so the tentorium will be cut. And you see that the arachnoid here is very nicely defined. Unfortunately, the vessels were not that easy to be dissected free from the tumor, but it was feasible. Use high magnification, it always helps, but don't forget about the general overview, because you may do something which is hidden to your vision with the high magnification. This is the temporal opening, just to expose the base of the temporal lobe to see the tumor entirely. This is already the temporal lobe. Then a little stitch to the tentorium, it helps the retraction, and any millimeter of retraction in this region is very helpful. And only the retraction and the orientation is good, you go for resection. This is the lobule underneath the temporal lobe, and resecting this and going medially. You see that now we have the rough surface of the tumor, not the smooth and shiny. And the first important structures you disclose here will be the corpus callosum from posterior. And you just remove the tumor small, and it's not well edited, it's rather long. Cues always helps, if possible. And exactly as you are decreasing the tumor in size, you are exposing the structures gradually. And now we get to the corpus callosum, the whitish structure at the back. And only at this point we shall find the extension of the tumor into the velum interpositum. And again, you will follow it. You will take care about the venous drainage, because definitely that is the most endangered structure here, along with the vein of Galen, along with the Rosenthal veins. All these veins really must be preserved, and you really would like to clear them from the tumor. You see, this is one of the one of the Rosenthal veins, the right-sided one. This is the internal cerebral vein, and here is the extension of the tumor into the velum interpositum, into the third ventricle virtually, and all the time it is the same, trying to keep within the arachnoid plane, not going out, just really preserving all the structures and knowing that there will be the internal cerebral veins. Okay, you lift the tumor from the quadrigeminal plate, which is over here, and you finish the procedure by resecting the left side of the tumor. This is the left Rosenthal vein, again, to be preserved. And this is the quadrigeminal plate. Here the only one structure to be preserved, which is the vein of cerebral mesencephalon, very tiny one in the midline, but usually shifted to the side by the tumor, but you would like to see it. And here is the entrance into the third ventricle, all the veins preserved, and the tumor remnant on the left side is last to be resected. This is after the surgery, and you see that the velum interpositum is free of tumor by now. So let's go to complexity very shortly, because there are a few questions to be answered. It is the eloquency of the brain, it is the veins, and it is the sinuses. In my mind, these are the three important points in convexity tumors. We've published this Rolandic area meningiomas. You really want to have intraoperative cortical mapping and stimulation, because that tells you everything. And you would like to know about the mode of growth of the tumor. It's either non-adhesive, where you preserve the arachnoid and all the structures underneath, or it's adherent, where you damage the arachnoid, but you do not damage the ependyma. And then adhesive, today it's called invasive, and today it's the basis of all the classifications in the Blue Book. And here is where you will damage the cortex almost unavoidably, because there is no plane of dissection and there is no interface between the tumor and the brain. And again, it's about the arachnoid layers. If the tumor origin is in front of the motor area, then the sulcus of the motor strip will again have two arachnoids, which will keep you at bay, which will keep you outside the motor strip. Unlike in this case, where the tumor grows directly above the motor strip, then this is the dangerous one. As soon as this tumor is invasive, it's better to leave a piece behind. This tells you the pre-op images, functional DTI, intra-op monitoring. You see it here. This is the motor strips. They're very nicely covered and preserved, and you see that the responses are perfectly preserved and giving you good information. What about the veins? It's a recent dogma in all the lectures, and everyone tells you that the veins must be preserved at all costs. I'm rather hesitant about that, and I shall be heretic. Should the tumor be here, procedural, you would like to preserve this vein which is anterior to the tumor and which doesn't have any collateral flow. On the other hand, the large vein posterior to the tumor has extremely good connection to both Sylvian fissure and vein of Labe. So I wouldn't hesitate to sacrifice this vein at this point, because the collateral flow would be just okay. Reconstructing the veins, it's not like ECIC bypass. It's extremely difficult to suture the vein as well as the sinus. So I don't believe in that much. So I wouldn't hesitate, should the need be, to sacrifice this vein. So the information prior to surgery from your MR, angio, or whatever investigation about the venous drainage of the surrounding the tumor is very important. That's something which really is to be studied prior to surgery. And prior to surgery, one should be really aware of what he's going to meet. So sinuses, again, the venous drainage. check the sinuses carefully. All of them, whatever in the vicinity, whether it's occluded, whether there is still some flow, whatever happens. Again, we all have seen hundreds of lectures about the sinuses repair. Not many post-op NGOs were shown at these lectures. I'm really rather doubtful about the reconstruction of the sinus. The pressure is negative. It's thrombosis very easily. I've tried that several times. It's difficult. It's not an easy task. So if you leave a piece of the tumor behind, nothing really happens. If possible, wait for sinus occlusion. If the patient is oligosymptomatic or asymptomatic and you see a parasagittal tumor just occluding the sagittal sinus, you may wait for a year when the sinus is occluded and then you resect the tumor entirely. And again, study the veins and sinuses prior to surgery. Not always it is true. See this easy tumor in the angle of the sinuses, the side of the tumor, there is no transverse sinus, so you think, all right, this is easy for radical surgery. Not true. We had to leave a piece behind because from the anterior, the vein of Labbe was entering the junction. So we have to leave a piece of the tumor behind, despite the fact that the transverse sinus is occluded on this side or non-existent. Just the opposite is true in this case. The dominant sinus on the side of the tumor, so you would expect that a piece of the tumor will have to be left behind as a plug to the sinuses. Not true. Very straightforward and very easy complete surgery. So study it, get the information, but be prepared to change your attitude. General remarks, and this is for residents and students. First comes the knowledge, the simple craft of neurosurgery. It's the same as with Lee. He must be very good at drawing, and he is. That's really the basics. Without this, it's impossible. It's the regular anatomy, the knowledge, everything you have to learn. Then comes the trade and dexterity. It's practice and practice and practice. And usually the practice starts from normal anatomy. Those are the aneurysms. Nothing is shifted, nothing is moved. Those are very straightforward and easy surgeries. Best to train your anatomy, and then you can do those beautiful paintings with normal anatomy. And the last step is the idea, creativity. When you push forward and when you go for distorted anatomy, when you expect the structures to be there, expect them to be moved. So these are the steps to go, but really the basics is the knowledge, the basic knowledge of anatomy. Although times have changed, in the 90s, we were the pilots of the jet fighters with no care about the collateral damage because we had the mission fulfilled. And there was only surgery, and we had nothing else. But then came the radiosurgery, interventional neurology, and also very legitimate wait-and-see policy. So just now we should behave like the airline pilots. Something's wrong. Okay, let's go down. Let's land. Not the jet fighters again. Don't get this attitude. That was extremely dangerous for the patients. Then there are things where you do not do anything. This is a young lady, 43, vision disturbance, cavernous sinus tumor, encased carotid artery. Nothing easy for surgery. Optic chiasm. You ask her for hormonal treatment, she tells you that she's receiving the female hormones. All right, the only thing and the easiest thing is to take the treatment away, if possible, and see in 4 years, the tumor is much smaller, the patient is asymptomatic, she's having her tumor, but she doesn't need any treatment. And should the treatment be necessary, that would be gamma knife and see that the chiasm now is free. So the dose can be delivered in its entirety, unlike here, where you wouldn't be able to do that. And surgically, this would be a difficult tumor. So what's important in meningiomas in general? Simpson 1 resection means cure quite frequently. Not always, but most frequently. And Simpson 1 should be the aim of our surgeries. That's our goal. That's what we know how to do. And that's what we all like to do. It really brings the best result to the patient. But the aim of meningioma treatment is not only to remove the tumor, it is to ensure the patient the high quality life, means normal life, of its given length, up to 8 years. And this is what the treatment means. It's not only surgery, it's everything else as well, like radiosurgery, like observation, like even some medical treatment. Do not treat Simpson 1 resection for neurological deficit. It's always wrong. You always would like to help the patient to ensure him the high quality of life, but it doesn't always mean that the tumor must be absent after the surgery. Also, just recently, not recently, but for quite a long, there are lectures and publications about meningiomas where there is no mortality and very low morbidity. I somehow can't not to believe too much in this, because there definitely is mortality in meningioma surgery. It cannot be avoided. And there is morbidity. You got these patients who are too much too late. I will show you one of these cases just now. But this is a young lady of 45, simple CP angle meningioma, easy surgery. The patient has awoken from surgery very nicely. And for 3 days, she was completely asymptomatic. On day 4, this bleeding to the opposite side thalamus happened and the patient died. So there is mortality in meningioma surgery, unavoidable and impossible to not to talk about. 90 years old patient with progressive hemiparesis. You have to do something because there's no other option. But you may expect that a 90 years old patient with ischemic heart disease, with diabetes insipidus and progressive deficit, the rate of success is very, very low. What we did in this case, and we were lucky that we resected the tumor under the OPMR control. This is what we left behind, just adherent to the motor strip. And the guy, we were happy and probably even lucky. The guy survived and he lived for another 3 years, and his hemiparesis improved. So this is these are the cases of too much too late, where you can hardly expect a good result, but it's almost impossible to decline surgery. So there definitely is morbidity and there is mortality in meningioma surgery. But there were the remnants, and this is again the treatment of meningioma, two proclival meningiomas, and I believe Luis Borba will talk about more, but this is not about the location, this is about the remnant. You see that there was no plane of dissection between the mesencephalon and the tumor, so these tiny parts of the meningiomas were left behind. In this case, the tumor doesn't grow for 10 years and the patient is asymptomatic, leading completely normal life, and he's just coming for checkups. In this case, the tumor grew, so we used radiosurgery, and again, the patient is living with the tumor for some 15 years, very asymptomatic, normal life. So this is the aim of meningioma surgery. What I would like to recommend the 3 articles we have put together with KNS skull-based group and some friends like Ken Joata, Samal Mefti, and others. There were proclival meningioma, then clinal meningiomas, tuberculum cellae, and those are really the consensus paper. We put it together, we all gave some thought to it, and this gives you probably the best recent overview of these 3 tumors. What we published was Simpson 4 meningioma, if it would improve with radiosurgery. Yes, it will. Then we've published the supra-infra approach, and it's suitable for meningioma. I show you one. Then we've published quite recently spinal meningioma. If the Simpson grade 2 is radical resection enough, it's not in younger patients. We see the relapse, so if possible, go for it. And when we were at meningiomas, we published meningiomas in dogs. You know, there were some 15 of them. Now there is far more. This is the petroclival meningioma or CP angle, the lateral pons in a dog and the patient after the surgery. It's surprisingly better result than the veterinary medicine. conclude and to give you the most important message from all the time before, arachnoid is a friend. Feel your friend, it gives you the space. And arachnoid belongs to the patient. So leave it behind. Stay in front of arachnoid. Do not go through if possible. In general, we were the WFNS neurosurgery anatomy since 2014. We were pushed on the web by the COVID, and we are doing very similar to what you are doing. We then converted into the International Academy of Neurosurgery Anatomy, and I would like to invite you to our bi-monthly webinars. The next one will be on 20th August, and we are also having lots of courses and hands-on life surgeries, whatever you name it, everywhere in the world. We prefer to go to disadvantaged countries like Africa or Southeast Asia and these places. This is the end from Prague, the capital of the Republic, the most beautiful city in the world, and I'm very objective in that. It's really the most beautiful, and this is final goodbye from my university, which is the being founded in 1348 by our King Charles IV, the oldest university in Europe, apart from the Italians, ones in Bologna and one other. Okay, thank you for your attention, and I hope that I didn't take too long.
So much for the amazing.
Thank you, Professor. Thank you, Professor Vladimir Tenis, for the state-of-art lecture in meningioma. It was a wonderful presentation. I think more than give another lecture, you should discuss everything that Professor Vladimir showed. You see, in one of the first slides, he showed the difference in vascular surgery and tumor surgery, especially related to the arachnoid. See, when you see picture of meningioma surgery, where the people show very well all the vessels, all the nerves, but without arachnoid, it means that problem in this surgery was not using the correct way to do the meningioma surgery. The idea, see, is to leave the arachnoid to the structures. It is our best friend, as Professor Vladimir just showed. But I want to ask you something, Professor, place by place, let's see, location by location, okay? First, the meningioma that few people pay attention a lot are the convexity meningioma. You talk about the veins, and I want to ask you difference. In that large convexity meningioma that is invading the bone, see, is a very vascularized lesion. You believe that there is a place, a role for preoperative embolization in this large convexity meningioma?
Louis, I would say there is. It should be considered. We did it several times, and my first experience with that was a lady who was like 87, 89 years old, huge convexity meningioma, exactly as you said, high vasculature, and the anesthesiologist told us we are not going to put her asleep. It's impossible, she's too ill. So what we did, we embolized the tumor. The tumor decreased in size. The embolization was perfect. I must admit that we have a very able guy. And the lady lived for another 5 years, and the tumor was small. It was she was finally asymptomatic. So time to time we use it very, very infrequently, but I still believe that there is some space for embolization in convexity meningiomas, either as a preoperative or even as a solo treatment. Should be considered.
And about the veins of the convective meningioma,
Ah.
what's the trick to preserve the vein? Is you have some trick. Sometimes you preserve the vein. See, everything looks okay, and the post-op you have thrombose. That's vein.
Yeah. Definitely.
There is
fully agree.
There is some intraoperative trick to preserve not just anatomically but functionally the vein.
Yeah, I do not have any specific trick. The only thing is helpful that there are small tributaries coming from the tumor going into the veins, and these must be dealt with individually, because if you tear them, then you coagulate down to the vein and you damage the vein. So as distant as possible from the mother vein, coagulate these tributaries and cut them sharply, and then try to dissect the vein. But you know, once you coagulate close to the vein shrinks and it may thrombose. So I do not have any specific trick. I really try to preserve the vein, but ultimately when I see that it's not possible, then I coagulate it. And in my experience, the danger of venous problems is not really that high. You may sacrifice some veins, especially as long as you are in non-eloquent area. So I wouldn't say that the rollover veins is overestimated, but definitely it is not underestimated by now. We are talking about them a lot, but do not have any specific trick. If you have some, tell me.
Yeah, the problem that you don't know what will happen with the vein. The majority of the time, there is nothing if you damage. But you don't know which one you have problem or not. Of course, you have the complex of Labbe, the trolar, the two most important veins that you cannot damage. But some veins, sometimes in the temporal pole, that's a very large vein that you can coagulate and nothing's happening. But in some situations, you have a temporal edema, because the preoperative angiogram, angio MRI, venous angio MRI can show you, give you some information, but it's anatomical information. It's not physiological information. Right. This is the difference, you see, because this, I'm always afraid about vein because I don't know what's happened. You see, maybe you coagulate and nothing happened. Maybe you don't coagulate and thrombose in the post-op, you have a venous infarct. Yeah. This is the problem, is the physiological more than anatomical relation. That
you are perfectly right. You are perfectly right. We do not know what will happen. We have no means to find out prior. So I would just say the larger the vein, more care should be taken off, and especially in eloquent areas. I think that the most dangerous area is really the region of vein of Labbe. And then Rolande, I'm not that much afraid about the Sylvian Fisher veins. You know that those big wing meningiomas, on the surface you see those engorged veins which are going into the sphenoparietal sinus, and to preserve these veins, it's almost impossible surgically, and usually nothing happens. But vein of Labbe and Rolandic area, those are really two areas where I'm extremely afraid, but I have no way to tell in advance. You can predict almost everything. You can predict the arteries, what will happen, but not the veins. There is no means. It's very variable system.
You know, you have a lot of residents online that resident will watch later, and people that start in neurosurgery. In convective meningioma, you remove the dura, just the meningioma, or you try to remove 2-3 centimeters around? Because there are a lot of papers showing that the recurrence is in this area. You like to remove more dura and do a duroplasty larger, or you just remove the tumor by itself?
No. I lift the dura, look underneath, and you see those little layers of the tumor. So I really try to get as far as beyond this margin. So it's like you said, probably 15, 20 millimeters. And this is technically, it doesn't matter whether you have to do small or large duroplasty. It's the same thing. So let's say 10 minutes of more suturing doesn't matter to the surgeon, doesn't matter to the patient. So the more I can remove, the more. Actually, the younger the patient, the more aggressive I am. It's a general rule. So in young patients, I even try to remove all the, to drill the tuberculum, to drill the wing more extensively than in the older patient. But, should I aim for Simpson 1 resection, then it's really Simpson 1 with far beyond the affected tissue. And I also prefer, if the bone is affected, the typical thing is to drill the bone and put it back. I like to have cranioplasty with some Alcos or whatever to remove the bone entirely.
Hello, Anna, go ahead.
No, sir, please
Noor?
go ahead. No, sir, please, sir, please go ahead.
Okay. Professor, about a parasagittal meningioma, or that the superior sagittal sinus is occlude or partially occlude. Which part you think that's safe to close the sinus? The anterior part, we know that's safe. The middle and third part, if it's occlude, I think it's possible to trust in this collateral vein, is occluded, or sometimes it's better to leave a small piece inside the sinus and follow or give radiation therapy. What's your approach for invasion of the superior sagittal sinus?
That's a difficult question. Actually, exactly as you said, the anterior third, I would sacrifice and I would resect it entirely. In the middle and posterior, I'm always very hesitant. It's not only the sinus, it's all of the veins which are entering the sinus. And you may see the sinus completely occluded at one point, and then you have entering veins from both sides into the sinus, which still is covered by the tumor and where the wall may be invaded. So I really take care about the veins which are entering the sinus. Exactly the case I've shown about the angle tumor where vein of Labe was entering the sinus. The sinus was occluded, non-existent, but there was still the vein which entered the sinus, and thus the sigmoid sinus must have been serviceable. And the same thing is with the superior sagittal. I enter the sinus, all right, you can tamponate it, you can suture it. I don't believe much in the direct repairs, like bypass, but I rather leave a piece of the tumor behind than to go for radical resection with the danger of venous infarction. So I like to stay on the safe side. Better a remnant than the deficit. And venous infarctions are rather difficult to fight. So middle and posterior third, I wouldn't sacrifice unless I'm sure that everything's occluded there. The bilateral tumors.
Hello, I want to make a comment regarding this vein dissection thing. What I have found actually really sharp dissection, even
please, Martin, please.
Yeah. Whenever we have these.
Please, wait. Say where you're from.
I am a former trainee of Professor Yashakil, and I worked in Auckland, New Zealand, in Toronto. Presently, then long time in Switzerland. I'm a Swiss. And right now I am a program director here in Dubai, and that will end
good.
because they're running
to
out
hear.
of money. They're running out of money. Anyhow.
Okay, go ahead.
You know, I spent hours in labs, you know, dissecting small vessels. And now when it comes to the veins, I found for some odd reason, you know, the micro scissors always tend to get you into trouble because they pinch things. Now, if you use any sharp blade, an 11 blade or whatever nice blade you have, the thing that doesn't need to be cut shies away from you. And when you dissect away these smaller branches from a major vein, being intimately together with the arachnoid of the meningioma, it is probably better to use a knife and accept a little bleeding from the small branches, put a patty there, put whatever hemostatic material you have, and be patient, and then kind of nature repairs that. You can even, I've had cases where I've had to had damage to internal cerebral vein. I just put something there, and then you know, the thrombocytes come, and eventually it was all fine. So I think that's the only thing I can remember. Yeah, thank you.
Yeah, it's a very nice, very nice. We also use a sharp technique, a sharp instrument to dissect the vein. But what you are talking about, the vein, is not the dissection by itself. Dissection, you can dissect carefully, you can preserve. We are talking about the vein, that you preserve the vein and later on thrombose. See, what I'm using as a trick is I use some warm water, warm irrigation to try to preserve the wall, and always do not leave this vein to be dry. See, this is one trick that I try to use that, but not always work. You see, vein is a very, very important thing. Thank you, Martin. Thank you. I think in Dubai you not have problem of money now. You can do a lot. Thank you, Martin. Thank you. You have if somebody want, if somebody want give some lecture for Professor Vladimir, please answer. Let's continue here, Professor. I will explore you, okay? I'm a little bit here. Yeah. Another question is, see your dissection in clinoidal meningioma. What we are using for clinoidal meningioma, you prefer to go first extradural, remove completely the clinoid, liberate the optic nerve. See? After you open the dura, the first step of our dissection is cut the falciform ligament, that you can liberate the optic nerve. I saw that you are doing the surgery intradural and after go extradural. You don't think that you go extradural first, you can cut the vascularization, can help you? What your opinion about that?
Luis, I'm going extradural, cut the falciform ligament, cut the distal ring, and only then I go intradural. And and then I let's say in half of the cases I only break the clinoid extradurally and don't try to remove it because I do not know the relation between the carotid and tumor and clinoid. And then I only then remove the tip of the clinoid, which is already free intradurally. But the approach is extradural.
Okay. Because of the most important thing when you are working around the optic nerve, see, before try to remove the tumor, is liberate the falciform ligament, because the optic nerve will be pushed over there. And the falciform is like a knife. It's extremely sharp. See,
exactly.
It almost cut the nerve there. See, if you liberate the falciform ligament, you give some space to the optic nerve, because always you try to mobilize as minimal as you can the optic nerve, but we always mobilize. See, if you leave this more free, it should be a great idea.
Exactly. You see the impression on the optic nerve by the falciform ligament. It's like pinkish line there. And when I drill, say 2 millimeters, 3 millimeters medial to the optic nerve. I start my drilling there, unroofing the canal, cutting the falciform ligament, and then you have a little space to move the optic nerve medially. That the optic is liberated first, of course, no doubt about that. Extraurally, then intraurally. Yeah.
There is a question here for Mohammed Ehagi about meningioma in elder patients. He is to a case above 70 years old.
Yeah, that's a problem. That's a problem because those
seizure.
Yeah. We are getting older as the population. We've got lots of octogenarians, and of course, there is more time for the diseases to grow. So we are seeing quite a lot of patients in their 80s, even 90s with meningiomas. And I would admit that unless the patient is symptomatic, we do nothing. We just follow the patients because the danger is ever present. If need be, then we do not hesitate to go for partial surgeries. Just the decompression, thus releasing the important structures and leaving the piece behind. The parts of the tumor which are invasive against the brain, better to leave behind, because these surgeries are exactly what I have said, too much, too late. You get patients who got large tumor, which is too symptomatic, and the patient is too ill to go through major surgery. So this is, in my mind, this is the most important problem of neurosurgery in future. It is the surgery in elderly patients. It's not only meningiomas, it's everywhere. We are seeing more and more of them, and we have less and less to offer them because they are more and more ill. So this is really a major problem, and especially in benign diseases like meningiomas, this is a big thing to discuss. Definitely.
Yeah, and you are seeing more and more, and the small tumor, and some people indicate surgery, and some people indicate radio surgery. Maybe these people don't need anything. Just live, they live.
Exactly. That's my policy. The older you get, the less aggressive surgeon you are. And I never, ever offer surgery to a patient who's got a small tumor, meningioma, schwannoma, whatever, unless he is symptomatic. I always wait, and I always want to prove the growth of the tumor. So first MR after half a year or a year, and only if the tumor grows, we start talking about the treatment, not earlier. The dynamics is the most important feature in all natural sciences. And in medicine, the dynamics is, in my mind, the most important. So if the tumor grows, if the tumor is becoming symptomatic, okay, let's talk the treatment. Never, ever before. Just to see for the first sight MR with the tumor and with the patient, I never offer surgery. I always wait for symptomatology or for the tumor growth in benign diseases.
It's very important, very important. See, the natural history of this tumor, more you know, more you understand the disease, more conservative you are. See?
Exactly. Exactly.
In the work from Denmark of acoustic neuroma, almost 15 to 20% of the tumor decrease in size.
Exactly.
You just follow the tumor and leave the patient. And in meningioma, is the natural history, I think, is more benign yet. More benign yet.
Fully agree.
It's very, very important. Yeah. There are some.
How many schwannomas do you follow? How many schwannomas do you just follow? Number. Great number. Yeah. The patient is phoning with the ear, the tumor is intracanalicular. Why offer surgery? No way.
Yes, very important, very important. There is some issue in meningioma, for example, if there is edema, there is something that there is some looks not a regular meningioma, something looks wrong. Maybe you can think that can be atypical or something different, but not that the nice one that is just a small ball in there. There is no way.
Exactly. You know, Luis, this is the difference in my mind between the evidence-based medicine and personalized medicine. You can have evidence-based medicine in, let's say, vascular neurosurgery, carotids, where we have CREST and the ICSS and all the other trials, ISAT for aneurysm, etc. No, not meningiomas. Meningioma treatment is individual treatment. You cannot expect to have some double-blind study which would give you the answers to all this. So you must really deal with your individual patient and decide which approach you would use. That's the beauty of medicine, of course.
Yeah. There is a question here about for falcotentorial meningiomas. See, which approach you prefer, or supracerebellar infratentorial, or transtentorial suboccipital? Of course, there is the extension of the tumor, but in general, what's your opinion?
Yeah. In general, for pure falcotentorial tumors, which are supratentorial then suboccipital approach along the angle is the best. But those are rare tumors. More of them are growing like around the falcotentorial angle, around the rectus sinus. So my preferable approach is supracerebellar infratentorial. But if the tumor is supratentorial also, then I have a larger craniotomy for supra-infra. I start supracerebellar infratentorial, but do not hesitate to go either interhemispheric or suboccipital or along the sinus through the supratentorial route. Sometimes even bilaterally, because then you can deal with the dura and with the rectus sinus. When you have approach from the both sides and from below, then you can resect both tentorial. You can cut the falx, you can cut the inferior sagittal sinus and remove the tumor along with all the dura. But for pure falcotentorial tumors, it's supratentorial, of course.
There has been some recent increase in the detection of atypical meningioma. Sir, what's your kind view in this regard? Do you have you also noticed that there's an increase in the incidence of atypical meningiomas, and what will be your guide suggestion in the management of this kind of typical meningiomas that we are seeing more commonly, much more than we have been before, like many of our seniors have also noticed?
Didn't hear you.
Atypical meningioma. What's your opinion about the incidence of atypical meningioma? Is more common now. We are doing more the diagnose. What's your approach for atypical meningioma? You do the surgery, you remove the tumor. If it remains a small piece, you give radiation or not. If there is total removal, you give radiation or not, or just wait. Atypical meningioma.
Atypical meningioma, if the resection is not a Simpson 1, we always go ahead with radiation. If the resection is really grade 1, Simpson 1, then we follow the patient first. But we are rather aggressive in that, because then the tumor starts growing everywhere, you know, and it's really a difficult issue. We deal with it like with the malignant tumor, which it obviously is. So we go ahead with radiation unless the resection is really radical.
Sir, but is it true that there's an increase in sense, because many of the people are saying that it's just because we are having much better diagnostic modalities and much more surgeries have taken place, like as compared to our previous experience. So maybe this is just a bias of caused by an increased number of surgeries and increased number of diagnostics that we are using. So it is not an actual increase in the atypical meningiomas. So, so it's a little confusing statements over here. So some people say that it's because of increased use of, maybe there's increased radiation use or increased use of mobile phones, etc., that's causing a rise in this atypical meningiomas, while mobile phones are more inclined to cause gliomas. Although there is no study that says that they cause any type of glioma or something like that. But still, so there is a confusing statement over here that whether there is an actual increase of atypical meningiomas or not. So this is something that is of our very much interest, and we are reading much more literature on atypical meningiomas than before.
If I understand, you are asking about the increase of numbers in meningiomas.
Exactly. So,
yeah,
so
definitely there is. I believe that the main reasons are two. The first, the population is getting older. We are living longer. That's the number one. And the number two is the density of CTs and MRs everywhere. You know, in my country, the CT is on every corner, and on the corner where it is not, there is MR. So you hit your head, and you got your MR. So we are seeing lots of patients who are truly asymptomatic, and the tumor is diagnosed by chance only. So this is probably the reason why we see more and more tumors. I don't think that they grow in somewhat more frequently than they did in the past. That's not biologically logical.
Exactly, sir. Exactly. So this is something that you know, it's a very metaphysical statements about it, for the describing whether it is a real or an actual increase, or it is because of an increase in diagnostics, increase in more meningiomas being operated. Thank you so much, sir. So there are a few questions in the chat box. I think, sir.
Maria, let me read one question here that's very interesting.
Yes, sir.
Marco Baralti. I don't know where he's from. He put in the chat here where he's from. The use of 48 hours in the pre-op of propranolol to reduce tumor vascularity in aggressive meningiomas. Did you hear about this?
I heard about it, but
for
I have
no,
I have no experience with that. We never somehow went into this business, so I cannot answer the question. I have no experience with that. Might be logical.
Yeah,
I don't know.
Marco, do you have some literature about this? They use the propranolol for meningioma. I hear about cavernomas.
And AVMs, I've read about the AVMs also.
AVM and hemangioma. But this could be a nice idea if it really works. See, he is from Cuba. Okay, good. Yes, I also have more questions here to Professor Vladimir.
Luis, to this vasculature, I just one comment, very short comment. Arteries usually are not a big problem. You can control the arteries, and you can control the tumor origin, even extradural, quite in very frequent cases. So the problems are still the veins.
Yeah. More and more, more you understand, more. One guy told me, as older as you get, more respect you have to the veins.
Yeah, exactly.
More respect you have to the veins.
Exactly.
Okay. I think you have 1 hour and a half exploring, Professor Vladimir. You need more and more questions. I see here that Hassan El Fertit just turned on his camera. I don't know if you want to make some question. If somebody want to make a question to Professor Vladimir, it was a wonderful morning for me and evening for you. And thank you very much for your outstanding presentation.
My pleasure and honor to be here.
Thank you.
It was really interesting. Good questions.
Yeah, you have.
There are quite a lot in chat, so I try to answer them by chat feature.
Okay.
I'll go through them.
Okay. My lecture about infratentorial will be in the next webinar. I am a little bit tired today, a little bit now to see my voice is a little bit different. And we hope soon you can be back to continue this. You know, Harvey Cushing said many, many years ago, there is no more gratifying for a neurosurgeon to a total removal of meningioma of neurological preservation. You think meningioma is our life as a neurosurgeon. Used to be aneurysm also, but today is changing too much. Meningioma is still our big business you keep to save the patient. Thank you, Professor. Thank you, all the participants. Thank you, Maria.
Thank you, sir. Sir, there's also an announcement to make, sir. I'm really pleased to announce that our collaborations with the ISBN and with the AANS CNS Tumor Association have been fruitful in a way that we are also organizing a course with the ISBN for pediatric neurosurgery. So the module 2 will be held this month on 26th of July, and I think I have shared the link to that particular module 2. And we have also got a glioblastoma awareness day webinar with the AANS CNS joint section on tumors. It will be held on 20th of July. That it's quite near from today, just 4 days from today. So kindly please to join us. We're really honored to have these amazing collaborations, and it's a huge honor for me and I think it's all because of Professor Luis Porba's dedication and passion for neurosurgical education, and we are really having it all, and people are appreciating this, and I think this will be really beneficial. So we owe a lot to mentors like you, Professor Porba, and Professor Vladimir Benz. I think it's a matter of great joy and pleasure for all of us, the young neurosurgeons, and I hope the medical students and the trainees as well, who are getting a lot of benefit from all these amazing webinars and courses. So I think, and sir, I think the module 2 will be about the infratentorial meningioma. The module 4 part 2 will be for the infratentorial meningiomas.
Thank you, Maria. You are superb. Always doing wonderful job. Thank you. Thank you, Professor. Thank you, all of you, and have a great weekend. Thank you.
Yeah.
Bye-bye.
Thank you, and bye-bye. It was a great pleasure to be here with you.
Thank you.
Anytime.
Thank you, Vladimir.
Thank you so much, Professor Vladimir. It's a matter of huge honor for us. You are so much popular in Pakistan. I can tell you. Most of my colleagues are a big fan of all your lectures. So thank you so much. I'm myself a big fan of all your literature and all your lectures. Thank you so much for coming.
You're welcome.
Well,
thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you.
Bye.